Good morning and happy Friday. My name is Amy Stengel, and I'm the Program Director for the Women's Leadership Initiative at the University of Delaware. We are thrilled to welcome you here this morning for what is the fourth in our Trailblazers and Changemakers series. And if you've been following our series, you know that we're highlighting the work of women who are really advocating for change. And while their expertise may be very different, the work that they are doing has a common thread. They're working for social change, social justice, and equity. We have one last webinar in our series coming up 2 weeks from today, Women Winning in Athletics. We hope maybe you can join us for that session as well. You can register on our website and you'll find the web address below. We'd really like to thank the sponsors who allow us to bring this webinar series to you free. So we'd like to highlight and thank Barclays, Delaware Today, InvestNet, Wawa, and we'd like to highlight our UD partner, PNC Bank, who's sharing this video from Cheryl Russo, Executive Vice President and Retail Executive for Philadelphia, Delaware, and Southern New Jersey.
Good morning, and thank you, Amy, for that introduction. My name is Cheryl Russo, and I'm a retail executive with PNC Bank. PNC is proud to be a sponsor this morning of this important and timely webinar series. In fact, it's closely aligned to a key focus area for us, and that's the importance of elevating women in the workplace. There are well-established, strong arguments for supporting and advocating for women in business. PNC thinks it's important because helping women accelerates economic growth overall. PNC has over 3,000 certified women's business advocates across our network who deliver business and personal financial products and services and resources that women need to thrive. Many of us know of what's driving the gap for women, but we can work together to help close it. And we can do that by inspiring women to consider typically male-dominated roles and industries. We can do it by leading by example and ensuring our businesses have family-friendly employee benefits and programs. And we can do it by enhancing access to capital. PNC is committed to financial equity for women, and we applaud the University of Delaware for presenting this series to empower women. Thank you for your time and attendance here today, and I now turn it back over to Amy.
So we're thrilled to partner again with PNC as our UD sponsor. And thank you, Cheryl, for your notes. We also wanted to just quickly mention our online certificate program. This is one of our newer offerings. We're launching our second cohort April 30th, and that cohort is actually sold out, but we have an October cohort and we'll begin filling seats as of May 1st. So if you're interested in more information, please look at our information on our web address, which you'll find on the slide below. A quick reminder, we are in the Zoom webinar format, and that means that while you can see us and hear us, we cannot see or hear you. We do highly encourage you to actively contribute in the chat with questions, thoughts, comments, resources. We welcome your conversation there, and we will try to get to any of the questions in the Q&A before we end our program. And if you happen to be live tweeting today, you can tag us on social media at UD Women Lead and using the hashtag Trailblazing And now it is my distinct honor and pleasure to introduce you to the two women who will be talking with us this morning, both Trailblazers and Changemakers. First is Dr. Marshala Lee, who is a board-certified family medicine physician and the director of the Harrington Value Institute Community Partnership Fund at ChristianaCare. Dr. Lee serves as the lead physician at Shortridge Academy's school-based health center sponsored by ChristianaCare. Her role supports efforts to strengthen community partnerships, mentor pre-medical students from underrepresented backgrounds, and develop new models of patient-centered healthcare that address the social determinants of health. Dr. Lee completed her undergraduate training at Tougaloo College, a historically Black college in Mississippi, prior to obtaining a medical degree with a concentration in advocacy and activism from Brown Medical School. She serves as the co-chair of the Wilmington Alumni Chapter of Delta Sigma Theta Sorority, Incorporated's Physical and Mental Health Committee, as well as supporter of numerous other community organizations. Welcome, Dr. Lee. We're so thrilled to have you here today. Also joining us today is Dr. Velma Scantlebury-White. She's professor of surgery at Texas Christian University and Medical School, University of North Texas Health Science Center, and a surgical transplant consultant and author. Dr. Scantlebury is the first Black female transplant surgeon of the United States. She has performed over 2,000 transplants and published many peer-reviewed papers. She has received many honors in her career, having been named to both the Best Doctors in America and Top Doctors in America lists multiple times. Dr. Scantlebury received her training at the University of Pittsburgh Medical Center. In 2008, she moved to Delaware to join ChristianaCare Health System as Associate Director of the Kidney Transplant Program and Director of Outpatient Services, retiring in 2020 to pursue an academic career. She has been involved with educating minority communities regarding the need for more organ donors and is an active community mentor and an honorary member of Delta Sigma Theta sorority, Wilmington, Delaware chapter. Welcome, Dr. Scantlebury-White. We are so thrilled to have these women here today who, as we go through this conversation, you will quickly learn are incredibly accomplished and have become incredibly passionate community activists for the issue of healthcare inequities. And as we get started, actually, I'd love for you to share a little bit with our audience today about what it was that inspired you to go into healthcare. And so, Dr. Lee, I know you've talked about the influence of your grandmother in your life and your choice of career path. Can you tell us a little bit about that?
Good morning, Amy. Thank you again for having me here today. It is an honor and pleasure, and to also be here with one of my sheroes, Dr. Scanterberry. So thank you again. There were numerous things that inspired me to go into medicine, but my grandmother, Mrs. Monetta Hill, is one of the major contributors to why I decided to go into medicine. She was a registered nurse, but prior to becoming a registered nurse, she was actually a field reporter for the Student Nonviolent Coordinating Committee, which was a younger set of the civil rights movement. And so I recently found about her history, which is chronicled in a book called I've Got the Light of Freedom, where they actually interviewed her and told her story. And in the story, she said that she was actually drawn to the civil rights movement because of their influence on meeting the social needs of their community. So they were hosting a food drive in the community, and she walked up and wanted to know what was going on and signed up to be a volunteer. And that's actually what brought her to the civil rights movement. And that's also what led her to becoming a nurse, because during the 60s, in addition to trying to integrate hospitals, there was a movement to increase the number of Black nurses in Mississippi. And so as a child, as a young adult, she would always describe her experiences fighting for civil rights, but also her experiences becoming a nurse. And that really increased my drive and my motivation for going into medicine.
Amazing. It's really remarkable how prominent figures in our lives and our families can have such an influence. But your grandmother sounds like a remarkable woman. Yes. We're thrilled that she inspired you, because you're here today doing this incredible work. Dr. White, Scantlebury-White, as you as well, I know you've talked about growing up in Barbados, and that sort of led you to thinking about healthcare as a profession. Can you tell us a little bit about that?
Yeah, I grew up on, welcome everyone, and thank you so much for having me here. This is a tremendous opportunity for me to have this discussion here this morning. And yes, I grew up in Barbados, and early in my young age, I was challenged to write an essay on my career, and I had to think about what I wanted to be. And I always envisioned our family doctor who would come by, and I was drawn to the fact that he was so independent. He just had his own business, could do his own thing, make his own hours. And I was one of those people who saw myself as being that kind of entrepreneur. And later on in life, I had an older sister that passed in England. And it was, to me, something that I knew nothing about. I was pretty sad to find that I couldn't help her. And I thought about, what can I do to help others? And medicine for me was that opportunity to really reach out and do something to help other people. But at the same time, it allowed me to be able to say, I can create this path for myself, and I can get to a position where I can be my own boss. That was early on. I wanted to be my own boss. And so that led me to a career of helping others, and the medicine was it for me.
Amazing. So I know as either of you were younger women considering your futures and then choosing medicine, medical school is a daunting challenge for anybody. But I have to think that it must have been incredibly additionally challenging as women of color. And we've talked about some of the obstacles for each of you in your careers. Can you talk a little bit about what it was like, going through medical school and any of the challenges that you might have faced there?
Well, I'll go first. Certainly for me, getting into medical school was a tremendous opportunity. I have to say that I applied to Columbia only on the recommendation of a friend, a church friend, and I got into Columbia. And at that time, I was told the reason why I was admitted to Columbia because I was a token Black and they needed to fill the quota. So for me, I got into medical school, but I was determined that at the end of my 4 years, it wasn't going to say a token Black doctor. It was going to say doctor of medicine, and that was important to me. So I had to succeed. I had to win. And one of the things that I unfortunately, but fortunate, is because with every success there is failure, and I listened to the voices outside of me who told me I didn't have to study, and so I failed my first qualifying exam, and that was devastating to me. But it taught me something. It taught me that I don't need to listen to others. I need to find my own path and decide how and what I need to do to be successful. And so it kept me focused. It made me realize that my mindset and my determination is what I need to each and foremost focus on my goal of succeeding through medical school. And that was important. The second issue that happened to me in medical school was that I was also told that I didn't have what it took to be a surgeon. And I applied to surgery, and without that recommendation, I didn't match. And so while everybody else was celebrating on match day, I was finding a position of internship, and I did. But it also taught me also that other people have these concept of who you are and can create barriers that may prevent you from getting there. And so, yeah, I took another path. I may not have ended up where I thought I wanted to be, but it still propelled my career. And so for me, it was keeping focused, determined that I was not going to let those negativities hold me back, and remain in my mindset that I had to win. And so that was it. A failure, we all come across it, we meet it. It's about using those failures, whether as an obstacle, not seeing it as an obstacle, but seeing them as challenges that you can overcome and succeed.
And so for me, I had a number of challenges in medical school. I'll always be indebted to Brown and Tougaloo College because they have a pre-existing, a long-term partnership since the 60s, where students from Tougaloo, which is a small historically Black college in Mississippi, are identified in their sophomore year as promising students and are granted early admission to Brown Medical School. So I knew very early that I was admitted to medical school and didn't have to take the MCAT, which is known to be a major challenge and not a good predictor of future success of physicians. And so getting into medical school wasn't a significant challenge, but I ran into a number of other challenges in medical school. My eyesight had started deteriorating prior to medical school. In my first year of medical school, it started rapidly deteriorating, and partially due to stress. And I found out that I had a progressive eye disease disorder that has caused me to be legally blind. And so leaving Mississippi to go to Rhode Island to medical school in itself caused significant challenges, but also to become legally blind your first year of medical school was devastating. But thankfully, I had encountered a number of other significant challenges in my life. So I was pretty determined and resilient and knew that, okay, this is just another barrier that's in my life, that I haven't come this far. I haven't been blessed with this many skills for the Lord to lead me. So it was my faith that really brought me through and encouraged me and inspired me to continue despite that new disability. And so I felt that I was smart and capable, but there were some external factors that also oftentimes caused me to challenge myself. And I even remember an attending who thought that she was providing some constructive feedback, actually encouraged me to lose my accent. And so even to this day, my accent is something that I'm still a bit self-conscious about, but that caused me in medical school to be self-conscious, and it oftentimes inhibited my participation in class because I was worrying about what others were thinking of me when I was speaking. So there were similar other challenges that I faced, but thankfully was able to persevere.
Incredibly powerful. Just one comment from somebody whom you respect and think is providing advice can impact you in such a meaningful way. And I think about both of your stories and the amount of resilience that it takes, when you talk about these now, not that it diminishes how difficult they were at the time, but it almost sounds easy to talk about, okay, these were the challenges I had. But when you really stop to think about what it took in those moments and those years across your experience in medical school, it's really remarkable. And so I know that in those times when there is just this constant push of negativity or difficulty, and you try to be resilient, there are also times when it does impact your mental health. And, Dr. Scantlebury-White, you shared with us actually a story about an unlikely ally that you came across in the operating room who sort of gave you permission to talk about this issue of mental health. Would you mind sharing that story?
Absolutely. Well, I left Harlem Hospital as a chief resident on top of the world in charge, and went out to University of Pittsburgh to do a fellowship in multi-organ transplantation. And at University of Pittsburgh, there were no other women in surgery. And in my fellowship, there were 3 of us as women. I was the only African American. And the first year, second year, it was quite a daunting experience. Not having anyone to relate to. In our fellowship years, it seemed as if we had a motto, was a fix, blame, and criticize. We could do nothing right. And so the negativity and feeling like I was on the lower bottom of the totem pole, I became depressed. I was not happy. I wasn't being trained in the way I thought I was, in terms of rejection from my patients, rejection from even my colleagues, in terms of turf and all the negative stuff, or the weekend call, or the things that other people didn't want to do. And I think my self-esteem just hit rock bottom. And I was struggling to be a mom, understand and do this job, and still be a great surgeon. And I was dealing with that. And one day I was in the operating room, and one of my colleagues was talking about, being jovial. He was a very, very dynamic surgeon from South America. And he went on and on about how happy he was today. He says, I am so glad when my Prozac works. He says, I know it's really kicked in when I don't give a damn. And he opened up that door for me to understand that I wasn't the only one who was feeling so discouraged, who was feeling down, who was feeling depressed. And he went on to talk about working and the constant drudgery of what we did, the day in, day out, the negativity. And he allowed me to see that what I was facing, I was not alone. And it was okay for me to admit that I was depressed, and that it wasn't just hormonal, and that all these other things I was blaming it on. And so that allowed me to say, I need help. If he, as a professor and a top surgeon, can admit that he needs some additional source to help him get through the day, then that allowed me to say, this is something I need to do for myself. And that was hard to admit, because everyone around you was saying, oh, you'll get over it. Just think positive. It'll go away. And depression is thus not something that you can choose to make go away. And oftentimes, no matter how you see yourself in those situations, it can be difficult. And so that was for me. Yeah, I went to my doctor, explained to it that my ginkgo biloba wasn't working. And I need something stronger than that. So that was my story.
So appreciate you sharing that story. I think it's so powerful. Certainly the concept of mental health has become more and more critical and more talked about through the pandemic. And it's hard for people to kind of admit and talk about. So we appreciate your sharing that story. In particular, I think as we start to go into a conversation about what is currently happening. So both of you have these journeys that have prepared you for this body of work that you are now both really passionately involved with. And I want to start that conversation by addressing COVID. So we know that COVID has disproportionately impacted Black and Brown communities, and we've seen the rates, unfortunately, actually getting worse rather than better. So have you been doing this work and trying to impact this trajectory where we're trying to close the gap, not only of just overall deaths for people in the Black and Brown community, but also closing this gap that has actually widened between white people impacted by COVID and Black and Brown communities. What are you seeing related to this trend, and what can we do to try to impact that?
I'll start by saying early in March, once we knew more about how COVID was transmitted and the risk factors, there were early signs that Black and Brown communities were going to be disproportionately affected. And so as a Black woman, as a Black physician, as a Black public health worker, it was very disheartening to see that there wasn't enough focus on these disparities and a call to action to mitigate some of these disparities. And so early on through our sorority, I said I needed to do something. And so we very early started a webinar series to just spread the word to our community about COVID-19 and to get the word out, because it seemed like many of our relatives, my friends and family, there was a delay in them even understanding how COVID-19 was transmitted and things that we could do to stop the spread. And so early on, that inspired me and showed me that we had to stand up for our community, because COVID-19 was something that was affecting everyone. And so everyone was concerned about their families. And if we didn't dedicate our time to protecting our community, then unfortunately it may not happen. And so since then, I've been working in a number of capacities to provide education, increasing access to testing, as well as to the vaccine, working with community partners to increase access, as well as from a policy level, because we know that advocacy is good, but unless it moves policy and puts funding towards and funding and resources towards the communities that need them the most, our efforts are futile. And so I'm now working to ensure that more resources are going towards the communities to expand access to the COVID-19 vaccine and work to overcome some of the mistrust that exists within our community in regards to the health system and vaccines.
And I'm going to add that it's important to understand that there are often unrecognized systemic inequities in place that prevent people of color from getting to the resources, even if the resources are there. You think about with COVID-19 testing and the fact that early on getting a test required a prescription and you needed to go to your doctor to get that, or you had to have symptoms. And that the places to go to get tested may not necessarily be in the Black and Brown areas that were convenient for those who needed them. And so they may have to take 2 buses and a train to get to a COVID test. So those are the inequities that we need to think about, and we also that affected people of color in communities from getting tested. And the same thing in terms of vaccinations. When we think about the fact that you will have a vaccine site, think about what resources, who's going to get to that site if you place it strategically in an area that is not accessible to those communities. Even the inequities of technology, needing pre-registration in advance. When you think about the elderly or those who don't have a smartphone, how difficult it is to register on your phone, even if you do know that technology, and to navigate that system or to be able to go to a website and find out where can I go to get that vaccine. So there is those inequities that are in place that we need to realize that we need to think outside the box and and that there may be resources. You may have a resource as simple as maybe Uber is taking people to their vaccinations, but if that resource is not known, then how would they take advantage of that? So those are the limitations that we have that are structurally in place that limits availability, access to those who need those kind of services.
Absolutely. And I know each of you has been working on some very specific initiatives along those lines. So Dr. Scantlebury, you shared with us that you're working with the Black Doctors COVID Consortium. Can you talk a little bit about what they're doing?
Yeah, Dr. Ella Stanford is one of my mentees, and we go back to University of Pittsburgh. And so in March and April last year, she was devastated also with the outcomes of Black and Brown people dying at tremendous rates compared to everyone else, and the lack of accessibility, even more so in Philadelphia. So she founded the Black Doctors COVID Consortium in an effort to really bring that COVID testing into the neighborhoods of Philadelphia. She got a van. She got volunteer medical students. We called on students from Philadelphia College of Osteopathic Medicine come out and volunteers. Everyone was home, and she started that organization to really get people tested, to go door to door, to go to churches. She partnered with churches, and so that's the foundation that have evolved from testing with COVID, eliminating those disparities, getting people to be able to say, I can walk up and get tested. I don't need an appointment. I don't need a prescription. I don't have to have a primary physician in order to refer me. And so those barriers were eliminated, and she carried that through to vaccination, where she vaccinates now in the Black and Brown neighborhood. She's intentional about zip code registration, zip code walk-up, so that patients who are underserved can get their vaccines. And that's so very important. And so you don't need an appointment. You don't need to have insurance. Yes, you can register beforehand, but you can also find the location and get there. And that is what we need to be able to do to deliver vaccination to underserved and to be intentional. And she's intentional in saying that I want 75 and 80% of the population that I'm delivering vaccinations to be people of color.
Amazing work. Dr. Lee, I know you've also talked about vaccinations, and as we were talking before this webinar, you talked about, families concerned about getting their own, family members vaccinated, and I think you had some thoughts about, what it takes to help get Black and Brown communities vaccinated. Do you want to comment a little bit about that as well?
Yes. Early on, there was some disregard of the concerns of Black and Brown communities in regards to the vaccine. Many people attributed to a lack of information or them not being educated, and without a real understanding of the logical rationale and explanations for mistrust. We oftentimes forget that our hospitals weren't integrated until the 1964, 1965. And many hospitals since then have not had significant efforts to really integrate our hospitals and address the differences that exist within our communities to overcome those barriers. So really our hospitals were integrated overnight without a clear plan and strategy for how we were going to provide equitable care to all of our populations and communities. And not only that, but there were significant injustices that were done in medicine. One of my role models is Fannie Lou Hamer. I'm not sure if you guys know her, but she is was a well-known politician, political activist from Mississippi, who was coined with the term, I'm sick and tired of being sick and tired. So even then, as a Black woman, she wasn't a physician, but she used her voice to advocate for health injustices and social inequities at that time. And believe it or not, she was also a victim of injustices in medicine. She went into the hospital for removal of a tumor and received a hysterectomy. They coined it the Mississippi appendectomy. And so these injustices that have occurred in medicine are not as distant for many people. I have even suffered from inequity, injustices in the healthcare system and mistreatment as a patient. And so without addressing people's concerns and providing them with the explanation of what we're doing to overcome and change the system, we're not going to overcome the mistrust. So number one, we have to be honest, open, and transparent about the areas that we need to still continue to improve. And also, we know the importance of trusted messengers. Dr. Scanterberry and I, as Black women, I try to be open and honest. We try to be open and honest with the community to say, I even had a level of mistrust when the vaccine was created. Operation Warp Speed, I don't want that in my body. And after we had the opportunity to evaluate the data and understand that it was safe and effective, I've been using that to educate the community and to show it to them as well. So one, overcoming the mistrust, and then providing them with the data to evaluate and understand for themselves. Those are two major strategies that are helpful in addition to making sure that the vaccine is accessible. I also think that we spent too much time early on explaining the vaccine disparities as being due to mistrust, when actually I believe the accessibility was a bigger barrier than the mistrust was.
Unbelievable. And I think about what you just raised around the systemic issues. And, so COVID has really shined a light for many people on what some of these issues are. But let's talk about now that some of those systemic issues, and as you've just suggested, some of the things that need to happen. So we know, interestingly, the CDC last week actually declared that racism is a serious public health threat. And so that declaration hopefully will start to have an impact on this issue. But let's unpack that a little bit when we talk about what the serious public health threat means. Why is racism a serious public health threat? Can you comment on, from your perspectives and your experience, how you see that showing up?
I'll start by saying that we all know that racism is systemic. It has been existing for hundreds of years. We have a behavior that has been ingrained into and socialized into our everyday action. For people, this behavior allows this separation based on what we see as a hierarchy of class. Somebody has to be on the top, somebody has to be on the bottom. And so when you separate someone by race or by color, you're devaluing that person because you're saying someone is less than you. And so how you treat people, how you interact with people, how you see them affects is biased by your view of that person and their color. And so as a person of color, I may be a surgeon, I may be a transplant surgeon, I may be a woman, but I'm still a Black woman. And it wears on you because you have that lack of credibility when you walk into a room, because they see you as a Black woman and not as someone who has that capability. And even as physicians, and so how you treat your patients, how they treat me is reflected in those biases. And we all have those biases. We all internalize, or we maybe have stereotypes of different people, but if we turn those thoughts into actions, and those little microaggressions and those biases then affect how you treat people. And even in terms of the reality is that even within healthcare, within our own healthcare, there's racism. There is from physicians to patients and patients to physician. And one of the things we need to recognize is that we have to check ourselves in terms of, are you devaluing someone? One of my patients said to me, I go as a patient with kidney disease. He says, I see my doctor. I make sure every day, every visit, every month or every other month, I go to see him. I put on a suit. I make sure I'm dressed appropriately. But every visit, he never calls me by my name, or he never looks me in the eye. And it may be something as simple as, how you doing, man? And he says, that eats away at your own dignity, because you're not seeing that person for who they are, or whether you want to be able to think that you're getting on their level but that's disrespect, and those things can chew away at just your self-esteem. And so that behavior, that systemic racism, is something we need to address because it's institutionalized. We need to be able to talk about racism, be able to address those at a medical school level, at a lower level, so that we don't carry them through the next generation, and address them at a physician level, how we treat our patients. And because even if I'm getting that impact to me as a person of color from my colleagues or the people I work with, then yeah, I'm sure the patients are also getting it. So racism is real. It's a serious health threat. It has existed, but we've unpacked it because of current situations and the things that we have encountered. And so, yes, we need to get to the bottom of this, and each of us need to check ourselves, how you treat others, how you treat our patients, how you treat, and our inability to interact and intervene with each other is affected by our bias.
And thank you. Before Dr. Lee, you jump in, I just wanted to ask Dr. Scantlebury, I know you shared a story when we were talking before the webinar about how you dressed for meetings.
Yeah, one of the things that for me is important, that even if I work all night and go home and take a shower, I'm not going to put on scrubs, because I want to make sure that I bring my best self to work. And that you see me, that you respect me for who I am. And there may be other reasons why you don't see me as a Black woman or as a Black surgeon, but it's important to me. I don't wear a white coat. I make sure that you don't have that barrier of sterility there, so that I can relate to my patients and be open and honest about who I am each and every day. And so that's important to me.
And I love that you shared for some meetings you would wear hot pink or red or yellow, so people would see you.
Yes, definitely, because I go to meetings, and whether it's a national meeting or transplant meeting, an American College of Surgeons meeting, and people I've worked with for many years, and I know them, and I walk past, and you see I'm wearing red today, and they're just walk right by you, and I touched you, and I says, "Hey, Mark, how you doing?" And the response is, "Well, I didn't see you." Is it that you chose not to see me? Because yes, I'm wearing bright canary yellow. How could you miss me? And so those things are the little microaggressions, because you don't want to see me. Maybe I'm in your space, and I'm not one who will lift you up or allow you to be greater than who you are. And so I don't exist. And that is something that just, it's like a little mosquito bite from day to day, just sort of gnaws away at you.
Mm-hmm. Absolutely. Dr. Lee, let's ask you from your perspective to talk a little bit about this issue.
Yes, so recently we've been paying more attention to the impact of the social determinants of health, but there hasn't been a direct linkage among enough of us to the factors that led to the disparities in the social determinants of health. And so structural racism is the backing of why those disparities exist. Also recently, there's been a call out of racism and not race as a leading driver of the social determinants of health. For many years, people were trying to say that Black people were born genetically inferior or predisposed to different conditions. And we're learning more and more about epigenetics and the impact of our environment and those social inequities, and actually changing our genetic makeup and causing us to be predisposed or more likely to suffer from chronic disease disparities. And so it's not that we're born genetically inferior, but our environment and those social inequities that have been put into place due to structural racism are a major driver of the social determinants of health that exist today. So we have to continue to address those factors such as education, employment inequities that we know affect the outcomes, our health outcomes, but also racism, because a Black college educated woman is as likely or more likely to suffer poor health outcomes than a white woman that only has a high school education. So we know that education alone and those social determinants of health without addressing racism, we won't be able to overcome those health disparities.
It is just stunning when you see the data on those issues where education and even socioeconomic status is not a factor either. So Black communities that are wealthy are having just the same amount of issues and premature health issues and deaths. It's not just about being low income. We have great questions coming through the chat. I want to just turn quickly to, we have one of our undergraduate students, Gabrielle Sherba. She's in the honors program at UD, has two questions to ask each of you. And so I'll ask her to jump in with her questions quickly, and then we will address a few of the questions from the chat. So Gabrielle, let me turn it over to you.
Hi, Dr. Lee and Dr. Scantleberry. I've loved hearing your story, and I just want to thank you really quickly for sharing, because I know that the trauma of sharing also can be a thing, especially with this. So just thank you very much. But my first question is, what does it mean for you as Black women who are doctors to be resilient in the face of inequality within the medical field while also advocating for better?
I guess Marsha's waiting for me to go first. You know, becoming a surgeon being a Black woman doing surgery in a field that's male dominated, where there are very few. I trained where there were no other Black women. There were residents who I took under my wings. But oftentimes it's important to maintain your focus, maintain your passion, understand why you're there, and that you will have an outcome, and you want to have that outcome being a successful outcome. And sometimes it's hard not to trying to keep the noise out and all the voices of other people who begin to stifle your own voice and your own passion. But you have to stay grounded, you have to stay committed, and sometimes you need some reinforcement, and so you pull in those reinforcements when you need them. But I have to say, my resilience comes from having my faith in God, staying focused, and knowing that at the end of the journey, while it may take me longer to get there, but if I stay determined that I'm going to succeed despite the failures, despite the negativity, despite the biases, despite the racism, that I'm going to overcome. And then I remain committed to myself, to not be distracted by those resources, and to make sure that I maintain my own health and well-being so that I can be a source of help and inspiration for others. Because that's so important for me to be able to bring others along and let them know that despite my humble background, that they too can succeed.
And I co-sign everything that Dr. Scanterberry-White has said, but want to also add that being resilient means that understanding that I can't do everything by myself. I oftentimes felt like I was superwoman and felt that I couldn't trust others. And so being resilient means being able to build a portfolio of trusted advisors, a portfolio of trusted resources, and not being afraid to reach out for help. Dr. Scanterberry-White is teaching me the importance of self-care. I have high blood pressure, and oftentimes I'm running, and don't make time to exercise and eat healthy because I'm eating on the go. And sometimes I'm even stress eating. So I've been more cautious of the fact that in order for me to be there for my community, I have to take care of my health. And so that's what's been inspiring me lately, is that although there are immediate needs that I need to hopefully address with COVID and other health and disparities, being resilient means that I have to develop healthy coping mechanisms and healthy strategies for addressing those inequities so that I'm here for the long haul. And so it's no coincidence that we are members of the same sorority, as well as I haven't formally joined Dr. Scanterberry-White's church, but we're both have a strong faith, and we tap into those resources to keep us going.
And I have to echo, it's so important to have a support mechanism. When I was out in Pittsburgh and I was there by myself, my family was in New York. They're seeing Pittsburgh was so far away. My husband's family was from North Carolina. Pittsburgh was in another world. And it was important for me to reach back to my church, reach out to my female organizations. And out of the blue, this lady came up to my driveway one day and said, "You don't know who I am, but I know you. I know your situation. I know you're new to the city and you don't know anyone. So I'm here to help you." She said, "And every Sunday I'm going to come by and watch the kids for you, and so you can have a chance to go to the mall, do something by yourself." And that was so very important to be able to have that support. And so it really does take a village, because you get so into the negativity and being all alone and not trying to be superwoman, and you're not. I remember the students in Mobile, Alabama gave me a t-shirt about, by being superwoman, but no, it's a struggle to be able to accomplish and do all the things that people expect you to do and still be yourself. And at the end of the day, you just want to go in the bathroom and close the door and scream.
Yeah, I really appreciate those comments. So my second question is just a little bit more broad. What have your personal experiences in medicine and otherwise taught you about the world that you want people to know?
Ooh, one of the things for me has been my journey. When I was in medical school and became a resident, an intern, I envisioned life in a whole different way. I envisioned that I would be in charge. I had that determination that I was going to be the boss. I'm going to rise to the top. There would be no obstacles. I didn't envision all these obstacles, but it definitely has humbled me and really, really. I grew up in a country in Barbados where everybody's black and brown. So dealing with racism has been very difficult. And after 30 something years, still trying to navigate the system and not let that constant daily drip of negativity chew away at my personality. So I have to believe and be inspired that there's good in human beings. And at the end of the day, there's hope. There's hope that I can imagine. And one of the opening sounds we heard was, I rise above the other side and rise above the voices and still maintain that hope that there are good human beings out there, and together we can rise above this negativity and this hate and have a better world of love and unity.
My experiences have taught me the importance of diversity and inclusion. Once we spend more time together, sit at the table together, and really get to know each other, we realize how similar we are and how there are minimal differences between us. And if we work together, how many of our families we're struggling with similar concerns, some unique concerns, but at the end of the day, we all care for our families, we care for our communities, and some of those factors are unique. But when we really sit down and get to know each other, it's harder to hate people that you don't know. And when you get to know people, know their heart, understand that they're working to care for their families just like you, I really think that diversity, not just diversity, but really getting to know each other and valuing our unique differences are what will allow us to better care for each other.
And one of the things that I joke about is sometimes patients want to know whether their organ, their kidney or liver came from a Black person or a white person. And the generally says, I don't know. That's not something I focus on, because in the inside, we all look alike. There's nothing different on the inside from that matter. So it really doesn't matter from that standpoint. And my colleague told me a story of, he worked in Tennessee for a while, and he had to do a liver transplant on one of the high orders of the Ku Klux Klan. And the person, had these tattoos on their body and stuff like that. And he said he was insulted after his operation, and he asked about where his liver came from, and he told him it came from a Black man. That shut him up. So he had to deal with that for the rest of his life. So,
sounds
in
like
some ways,
poetic justice in some ways, right?
yes, yeah.
Amazing. Well, thank you, Gabrielle, for jumping into our conversation. And this hour is flying by. And I want to make sure we do get to a couple of the questions from some of our participants in the chat. And so one of the first ones is, how can employers and companies help address health inequity? What can organizations do?
They have to be intentional and actually understand the impact of their policies and procedures on sometimes even worsening inequities. And so they really have to sit down, look at all of their policies and procedures and identify they call it with the equity lens. And so look at them and say, hey, does this policy, and have to be intentional about saying and evaluating each policy to say, does this worsen an inequity or does it reduce an inequity? And until you're able and willing to do that, you're not being intentional.
And it's important to also understand the difference in equity and equality. And, Dr. Lee talked about diversity. Who's at the table? Are there people of color? Are there gender differences? And you have to be willing to accept that diversity and see that diversity is a good thing, not that someone doesn't look like you, so therefore you're going to avoid them. But accept those differences and understand that diversity is going to improve the outcomes of your institution and your company, because it's going to bring a wealth of ideas and other avenues that you never thought about. And so you have to be willing to embrace that diversity. And then once you're intentional, as Dr. Lee said, of being able to say that we have inequities. Not everyone here have access or have the ability to be in this boardroom, and that you may want to change that. Then it's important to also be inclusive. So diversity is good, but if you don't have a voice and you just decide you're going to just hire a figurehead that, okay, we have a female and an Asian person on a board, and they're there, but you're not listening or not integrating their thoughts and their processes, and so therefore, it really boils down to examining your company and your practices and your policies. And are they just things that are there that limit the ability for a diverse population to rise to the top and to also be effective and have a voice in your company, and recognize that they too have abilities, but they come from a different place than you are, and be willing to embrace those differences.
Amazing. It occurs to me as well that companies with their large purchasing dollars, between where they choose to put their healthcare insurance with certain companies, or what they do with their philanthropic dollars, their foundations and supporting organizations that are focused on healthcare and equity work, is another maybe good way to think about what they can do from a purchasing perspective. So one of the other questions that came up, which is I think really interesting and getting more focus, and Dr. Lee, I know you've spent a bit of time working on this concept, but clinical trials, so clinical trials have historically been focused on maybe very limited demographics. How can we use clinical trials to expand access to healthcare for all people and engage more minorities?
Yes. We also know that the lack of diversity in clinical trials is a major factor in ensuring that healthcare services are geared towards all populations and are effective. Unfortunately, because of those past historical injustices such as Tuskegee, it has resulted in a fear and mistrust among minority communities. And so organizations such as the National Medical Association, for which I am the vice president for the Delaware chapter, through its Cobb Institute, they have taken a very aggressive approach in educating minority communities about the importance of enrolling in clinical trials, and how the makeup and diversity of those clinical trials impact the effectiveness and uptake of those medications and therapies among communities. And so I have personally enrolled in a NIH clinical trial. I have a rare liver disease. I have a couple of rare things going on in my body. And so I use that as a teachable moment to my community when I'm out educating about not only is a clinical trial ensuring that I'm able to get the most up-to-date technologies and medications, but again, as a Black woman, like many of us, I'm using my body to ensure that those technologies are safe and effective for my family and other communities of color for the future.
Fantastic. Thank you for sharing. So we have one last question, 2 minutes left before 10 o'clock. Do either of you have any insight into how medical education is addressing issues of diversity and equality? What are we doing in our medical education systems?
Well, I know that the medical schools have integrated a curriculum that's important from the very beginning to understand health equities, health inequities, and diversity and inclusion, and really addressing the racial and disparities within the healthcare system. So that's been discussed very early on, so that our medical students are understanding that they too need to enter the field knowledgeable and capable of understanding, being sensitive. Something as simple of unpacking the theory behind glomerular filtration rate, which is an estimation of how a kidney functions, has an equation that inserts whether you're Black or white into it in the outcome. And that's just something that just has been existing, but now it's being questioned. Why is it necessary? Why does it matter? How does it disadvantage people of color by having this formula there that impacts their overall results? And so those are things within the healthcare system that need to be addressed. And so early education and addressing those things. And now students have a voice. They're very outspoken, and that's for the betterment of our system and our institutions. So I'm very glad for that, because those are things that we address and discuss with our young budding doctors very early on.
And medical schools are doing a lot and taking an active role in addressing health disparities. But presently, African-American physicians comprise less than 5% of the physician workforce, and Native American and Indigenous physicians comprise less than 1% of the physician workforce. And so many medical schools are working to recruit more minority students, but there is a need for even more efforts to not only recruit a more diverse physician workforce, but ensuring that those training environments are inclusive and able to support students that come from backgrounds that may be more challenging. And so we know the benefits of a diverse workforce. Research has shown that they can lead to improved health outcomes and trust among patient populations. And so more work must be done to increase the diversity in the physician workforce. There are efforts, but we must do more. At Christiana Care, we have a MCAT prep program, which is the MCAT is the entry exam for medical school, which is known to be a barrier exam. We know that many of the standardized testing exams are barrier exams that prevent minorities from gaining entry to those professions. So there are active movements in place to consider if we should eliminate those exams. There have also been movements at holistic admission, where schools are not only evaluating students based upon their MCAT and grades, but their commitment to diversity and working to address health inequities through their social mission and volunteerism as well. And so more efforts must be done. But I'm glad about the efforts that have recently been incorporated to improve diversity in the health workforce.
Thank you so much for sharing your insights. And I see we're actually just past 10 o'clock. I think we could easily keep you here for another hour, but thanks so much to you both for sharing your time this morning, for your open dialogue, for being so open about your past experiences. And I just want to note to our participants that we do send out a follow-up email with resources, some of the organizations that have been talked about today. We'll note in that follow-up email if anyone is interested in finding out more. So thanks to everyone for joining us today. Have a wonderful Friday, and we'll talk to you soon.